Hello, my name is Dr. Paul Sachs from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. I'm just back from the conference on retroviruses and opportunistic infections, which just took place in Montreal, and where we were very lucky to have balmy 40-degree weather after a first day when it was about 5 degrees. This is just going to be a top 10 list of some of the highlights from that conference. I'm going to go very quickly, and then I refer you to the actual excellent conference website for you to see more details. There was important results on the interleukin-2 studies, Esprit and CILCAT. And essentially what they showed is that despite raising CD4 cell counts significantly, there was no clinical benefit to giving either patients with low CD4s or higher CD4s. So that question has been answered. IL-2 really has no benefit on top of antiretroviral therapy. Another important studies were those looking at when to start antiretroviral therapy. At ICAC, the NA Accord group found that starting before 350 was better than waiting till after. Here they looked at a threshold of 500 CD4s and again found that starting before the CD4 cell count fell below 500 was better than waiting. Another group, the ART cohort collaboration, found a slightly different answer, saying about 350 was better, but both studies sort of imply, even though they're cohort analyses, that we're better off starting before the CD4 cell count falls too low. There was a study called SwitchMerc, which looked at the strategy of switching patients who are stably suppressed on lopinavir-ritonavir-containing regimens to either continue that lopinavir-ritonavir-containing regimen or switch to raltegravir. They would then contain the nucleoside analogs. What the study found was that while the lipids improved, not surprisingly, there was actually an excess of virologic failures in those who switched to raltegravir. It seems that the likely explanation for this phenomenon is that patients who switched were potentially treatment experienced and might have harbored NRTI resistance and hence were not benefiting from the high resistance barrier seen in the boosted PIs. Essentially what this means is that we should use raltegravir as we've been using it, only with other fully active agents. This would be true in the treatment-naive or the treatment-experienced setting. Very important study from the developing country was one which showed that treating tuberculosis and HIV concurrently was better than waiting until the end of TB treatment. This is the SAPIT trial and was stopped early because the patients who waited until after the 6 months of treatment ended up having a significantly higher rate of death. Interestingly, the TB treatment outcomes were similar in the two arms, implying that the untreated HIV infection is what led to the worse outcome. There's still an analysis in that study going on comparing treatment right away with treatment starting after the first 2 months, which is the intensive TB treatment. Another important study from developing countries is one from Uganda, which demonstrated pretty convincingly that treatment does reduce the risk of HIV transmission. About 3,000 couples ended up being in this study. They were discordant couples, and antiviral therapy was started on those when it was clinically indicated for those who have HIV infection. There was a significant reduction in transmission, about 5-fold reduction, and importantly also, sexual risk behaviors did not increase. In fact, they went down somewhat in those who received HIV treatment. Risk of transmission, of course, is not zero. There were some studies showing persistent detection of virus in semen despite adequate therapy, but nonetheless, it is significantly reduced. There's been quite a bit of controversy about the potential role of antivirals in inducing cardiovascular disease, and in particular with abacavir. There were numerous studies on that at the conference, and in essence what they showed was as follows. There was a DAD study was updated which showed that abacavir again did have an excess cardiovascular risk, and a French hospital database study showed the same thing. Now, there were several negative studies there from the ACDG in particular, but importantly there was also a prospective clinical trial in patients who were stably suppressed, and they switched to either tenofovir FTC or abacavir 3TC, and after 96 weeks of follow-up there was a small but significantly excess risk of cardiovascular events in the abacavir arm. Now, the cause of this phenomenon is still not known. Pathogenesis studies were presented and they were kind of all over the map. What I encourage you to do is look at the website, the conference website, and watch Peter Reese's excellent summary of the various studies looking at abacavir risk. Another important couple of studies were two studies introducing non-ritonavir pharmacokinetic enhancers, one from Gilead, one from a company called CROI, and it's hopeful that these will have the PK boosting effects that are beneficial but not have some of the toxicity that's associated with ritonavir. There is an additional study which deserves mentioning, which is that a microbicide was shown to work for the very first time. This microbicide was called PRO1, I believe. Yes, it was and it was importantly, this is a microbicide that has HIV activity. And although the effect was not statistically significant, it is the first time that we've seen this effect in any microbicide trial. Often they show either no benefit in preventing HIV infection, or potentially they even can show harm. So that's kind of a quick run through some of the highlights of the most recent conference on retroviruses and opportunistic infections. And I also want to refer you for a bit more detail to my written summary of these events, which includes links to all of the abstracts. Just search HIV and ID observations in Google, and you'll probably end up finding it eventually. Thanks very much.